was saying that these main publications, these 3 surveys in Europe, in the US, and in Australia, show us that there are 3 main different disease categories. So in different countries, there are more prevalent the neuromuscular, like in the US. In Europe and in Australia, it's lung disease and airways disease that are most important. The French Untitled Observatory is quite important for us to follow the trends across the years. This is a study published in Respiration 2018, showing that really obesity hypoventilation syndrome is typically the disease that is on the rise, with 56% of startups in 2015. Concerning neuromuscular, it was only ALS that came first with 4% back in 2015. So let's focus a little bit on the obesity hypoventilation syndrome. That's probably the disease that typically comes more often to our clinics. And I start with a typical case. So this is a full PSG of a patient from our lab, a typical 59-year-old female with high BMI and with a high apnea-hypopnea index. And as you can see with this REM-related sleep hypoventilation, where you can see the saturation is going down periodically when the patient goes into sleep, typically associated with hypoventilation, and saturation goes down until 71%. I think that everybody knows the definition, but just to clarify a little bit, when we have a patient with a BMI above 30 and has daytime hypercapnia, which means PaCO2 above 45 at sea level, without any alternative diagnosis, without any lung function impairment, then we can say that this patient has obesity hypoventilation syndrome. What we know is that 70% of these patients with obesity hypoventilation have concomitant severe sleep apnea. That's the case of the patient that I showed to you. And the remaining have a kind of a non-obstructive sleep hypoventilation. And so it's important that you to identify these two kind of a phenotypes. And the ERJ, the sleep, the task force of the ERS has made this simple for us. And there is now a new staging for hypoventilation. As you can see, stage 1 is the patient that has some grade of hypoventilation during sleep, but still he recovers during the day, and there is no whatsoever CO2 retention, not even increased bicarbonate. The level 2 is when the patient is having also intermittent hypercapnia during sleep, but you can detect increase on bicarbonates above 27. The overt sleep hypoventilation syndrome or obesity hypoventilation syndrome is level 3 or stage 3, where you can have sustained hypercapnia while awake. And then we will have the level 4, which is the patient that not only has obesity hypoventilation, but has also some other cardiometabolic comorbidities like cardiac failure, pulmonary hypertension, etc. And I think very recently the ATS has also made available some important guidelines for the management of these patients. And so when we have a patient with suspected obesity hypoventilation that has these high bicarbonates during the daytime, it's important that you perform a sleep, and if you can try and do a sleep titration with full PSG monitoring as well, TaCO2. Sometimes the patient gets hospitalized with hypercapnic failure. Normally you will have to start NIV without any sleep study, and after discharge then you will have to do the sleep study after 3 months and do a retitration. Juan Fernando Massa from Cáceres in Spain has produced a lot of very important papers with the Sleep Spanish group, Sleep Spanish Network. And according to his group, CPAP can be the first choice of treatment, especially for this phenotype of obesity hypoventilation with more than 30 of hypopnea index. And there are good responders that normalize their arterial blood gas analysis. They don't have any exacerbation anymore. And so we maintain CPAP. For the ones that do not respond to CPAP, so there are still inadequate arterial blood gas control, then we can switch to NIV. And NIV will be the first choice for the patients that are with obesity, hypoventilation, and low apnea-hypopnea index. So to conclude this first part of my talk about the treatment of obesity hypoventilation, I think it's important that we start doing a screening for obese patients that come to our clinic and do some simple bicarbonate measurements. And the patients that need more priority are the ones with stage 4, so the ones with comorbidities, and the ones that are acutely exacerbated and have an episode of hypercapnic failure. For the ones that have severe sleep apnea, we could start with CPAP. For the ones that are non-obstructive sleep apnea predominant, we can start with NIV. And also switch to NIV for the ones that don't respond properly to CPAP. Titration of the parameters could be in lab. We can also use automatic CPAP for the ones that have severe OSA, but in the end, to just confirm the control of hypoventilation, we need to do a sleep titration. Let's move a little bit forward and concentrate on neuromuscular disease. Again, a case vignette. So this is a lady that came to our clinic some time ago now, 60-year-old, ALS already confirmed, lung function okay, so vital capacity 98%. PI max was pretty low, but maybe she didn't cooperate too much. Daytime SpO2 was 98. We didn't perform arterial blood gas analysis during the daytime. We tend not to do so much as in other patient diseases. And as you can see, we perform a full PSG. And if you look, there is no apneas, so the AHI is okay, as we would expect from a lean lady with ALS. Some arousals, not so high, and the mean saturation is okay. But when we look at the level of PaCO2, we can see that it's not showing, but I can tell you the mean TCO2, the transcutaneous, is 49, and the maximum is 53. So we have some degree of hypercapnia during REM sleep, as you can see now. The tracing is now showing that we would typically miss if we only performed an oximetry. And so it's important that you understand that neuromuscular patients, due to their diaphragmatic weakness and REM-related atonia, they can have some hypoventilation, they can have some pseudo-central events, and due to the hypotonia of the upper airway muscles, they can have also obstructive sleep apnea, and I will just come up to that question next. This is a very interesting study from Germany showing the prevalence of sleep apnea and hypoventilation in amyotrophic lateral sclerosis. And as you can see that AHI above 5 is pretty common. 45% of ALS patients in this big series, 250 patients at criteria for sleep apnea, obstructive sleep apnea. And even with a severe sleep apnea, the prevalence is 6.8. And what is unexpected is that this prevalence of sleep apnea is higher in patients that are male and that have bulbar dysfunction. And the importance of diagnosing obstructive sleep events at the baseline of neuromuscular, especially in amyotrophic lateral sclerosis, is the prognostic impact of obstructive sleep apnea at the onset. This is a study from Italy showing that patients on the green is the survival of patients with less than 5 per hour of events, and the black line is patients with more than 5. And as you can see, there is a pretty different survival. So there is a prognostic role of sleep apnea. And what about the patterns of oxy-capnography in ALS? Again, the study from the German group shows us at least 4 different patterns. So this is the first pattern is A, with intermittent desaturation without hypercapnia. So you can see there are pretty intermittent desaturation events with some more profound events and pretty normal CO2. This is the first part of the diagram. On diagram B, you can see there are desaturations in REM sleep, typically associated with increases in PaCO2. This is the most typical REM sleep-associated desaturation and hypoventilation. But then you can have hypoxemia and hypercapnia independent of the sleep stages. So CO2 is going up and goes smoothly and persistently, and the desaturation is also persistent all over the night. And the last panel is the one that is similar to the patient that I show you, which is the patient that has not significant desaturation, but the CO2 is pretty high. So it's isolated and with some, increases in REM. So in our patient, we decided to start by level, and we started with the typical parameters, 14/4. And as you can see, the compliance is pretty good. So this is the number of hours per day, and across 1 month. And she used the ventilator for 100%. And I think that there is no doubt that the patient is compliant. And if we go a little bit more into detail, we can see a full night with the parameters that I mentioned to you, and also there is the initiated breaths by the patient. We can see that the patient is pretty captured, so it's 22% of the breaths that the patient can trigger. And so there are some episodes of desaturation that we need to understand a little bit better. These were not present in the baseline study. So if we go a little bit deeper, we can understand that there are some new events, and so the AHI is 11.4, which is a little unexpected because at the baseline there was no event whatsoever. And if we go a little bit deeper into the tracing, this is the flow tracing, this is the pressure tracing on red, the flow on blue, and as you can see, like the device is telling us it's counting some obstructive episodes. And when we do at home the capnography, we can see that the CO2 levels are pretty controlled, the saturation is pretty controlled, but when the patient removes the ventilator, so you can see there is desaturation and there is increase in CO2. So there is an evidence that the ventilation is pretty controlled. So this is important. This is a very important seminal paper from Jesus González Bermejo in Paris-Salpêtrière University, showing that this is also an important prognostic factor. When your ALS patient has underlying non-corrected obstructive events while he's ventilated, so the prognostic is much worse compared to the patients with ALS that are on ventilation and they have corrected their obstructive events. So in this case of our patient, I was a little concerned that we should be looking a little bit more deeper on the causes of treatment-induced airway obstruction. This is something that is already described with a prevalence of 20% on ALS. There are other studies showing the same, especially induced by oral nasal masks. I can remind you that our patient was with a nasal mask. And also there are some collapsibility of the upper airway. And sometimes it's only the epiglottic that is moving backwards. And this is also a very important study from the group of Madrid, Javier Sayas-Catalan, first author, published in Respiratory Care, and showing very clearly that there are some role for upper airway endoscopy for us to understand the assessment of the response of the upper airway to a positive pressure. And we can use some kind of scoring system to define what is going on. Is it a glottic obstruction? Is it a supraglottic rotation of the area, epiglottic folds? And you're going to hear a little bit more on this on the next webinar. So this is the study from Javier Sayas-Catalan, where he was doing a full PSG coupled with laryngoscopy underneath, and you can see the epiglottis going, pushing backwards. And so this is sometimes a very difficult situation to resolve. We can increase a little bit the EPAP, or we can do like we did in one patient that had really the same. This is a publication a long time ago, where we used this device that is no longer available, which is a mask that had a phalange on the tongue that could just push down the tongue and avoid the glossoptosis that was appearing. What I can say about this lady, this patient, is that on the follow-up, we can see that she was still compliant some months ago. And as you can see, the AHI was coming down. So and the saturation was pretty okay, and we didn't do anything. So sometimes these events can be also due to some leaks, and so this can be some transient situation. So we must not act just immediately. We should be looking at these events to make sure that we don't have these residual events that can have a prognostic impact. So to conclude my the second part of my talk on neuromuscular disorders, I think I can convince you that it's no longer possible to start an all mechanical ventilation clinic without the resort of oxy-capnography, especially if you're dealing with neuromuscular patients. I think that these residual events are a challenge, so we need to understand them better by looking at the upper airway with some kind of titration, doing and on a trial and error, and maybe through polygraphy, synchronized by video laryngoscopy, like we are proposing, and the group of Javier is also proposing. So my last minutes, I will just deal with on one of the major indications we are having right now, which is chronic obstructive pulmonary disease. And so before I show you also a case vignette, I'm going to show you the most robust evidence that we have now that is come out from a recent meta-analysis published in JAMA in 2020 in February, just showing that all these studies that we're going to talk about in the next minutes just pulled together, and including more than 50,000 patients, shows that HMV just decreases the risk of mortality. So this is some signal that it's one of the first interventions that can have this so important outcome. And so coming now with a vignette of a patient. So this is a typical patient on the hospital with an acute exacerbation of COPD. So pretty acidotic, as you can see, pH 7.187, CO2 high, PaO2, so he's doing NIV on an intermediate respiratory care unit. Unfortunately, it could be reversed, so this situation could be reversed, and so the protocol now is you should be reviewing all your hypercapnic COPD exacerbation on your clinic 4 weeks after, and that's what we did. And so we performed the lung function, as you can see, pretty obstructed patients, so 40% of FEV1, and pretty insufflated patients, so high residual volume, high ratio residual volume to TLC, and still hypercapnic at 4 weeks, so CO2 of 55 millimeters of mercury. And as you can see, the PSG is also showing the same, so increases of CO2 coinciding with desaturation in REM sleep, so these red lines on the hypnogram, on the bottom of the hypnogram, shows these REM periods, and as you can see, not so many sleep apnea, so the patient had some events, but lower than 5 apnea hypopnea index. So it was an hypercapnic COPD patient without sleep apnea. And this is something that we need to screen. And this is coming out from the guidelines from the ATS published last year, especially patients which are overweight, so more than 25 of BMI, they should be screened for OSA before initiating long-term because of the high risk of overlap, because you probably need to consider different settings when you're titrating sleep, when you are titrating all mechanical ventilation. So let's start with the guideline from the European Respiratory Society in our patient population. So do we think that our hypercapnic patient, which is stable 4 weeks after an exacerbation with 55, is a candidate for long-term mechanical ventilation? Let's see what the guideline tells us about this. Well, the guideline is based on the randomized control trials, and this is one of the seminal papers by Kuhnlein published in the Lancet Respiratory Medicine Journal 2014. And this is patients really beyond the exacerbation, so really stable, more than 1 month after exacerbation. And this study, for the first time, showed us that if we treat patients not only with long-term oxygen, but with NIV targeted to reduce 20% of PaCO2, so we really improve survival. So we have 11% of survival in NIV versus 33% survival in the controls. And this we could have this improving in survival with a mean IPAP of 21 and a mean EPAP of 4.8. The emergency hospitalizations were not the main outcomes, but we could see also improvements in the quality of life measured by the SGRQ and the SRI. And so what about doing NIV on the long term after an exacerbation, so like it was our case? So I think that the study by the UK study, the HOT-HMV study, led by Patrick Murphy, really answered our question. So this patient was randomized 4 weeks after an exacerbation. The primary endpoint was admission-free survival. And as you can see here, the patients were a little bit higher on IPAP, so 26 mean IPAP. The FEV1 pretty low, around 24%, so lower even than our patients, so low BMIs, no OSA whatsoever. And as you can see, the admission-free survival was much better than in the HOT-HMV, so patients treated with oxygen plus NIV compared to the oxygen alone. And the compliance was at 3 months 4 hours per minute per day, but at 12 months it was really much higher. And the number needed to treat is quite low, so 6 patients are needed to treat to avoid 1 hospital readmission or death in 12 months. So this is a pretty robust outcome. And the secondary outcomes as also the quality of life. As you can see, it improved, measured by the SRI, but of course that it was going down because there was this was very severe patient population. And according to new trial data that are not still published, it was published in an abstract. I'm sure that it will be published soon. If they excluded patients randomized to the OHT alone, so patients that were only on oxygen, so there was really a reduction in all-cause mortality. And this was at an health economic impact. So this was a cost-effective, so with incremental cost per quality gained, really impressive. So what would be the target settings that we should aim for? So Wolfram Windisch some years ago just advised us to use high inspiratory pressures in the order of 28. That was his first publication. And he very elegantly, subsequently, just confirmed these impressions in a randomized trial, showing that the better outcomes, comparing high intensity, meaning high pressure to 29 versus low, which is 15 centimeters of water, we could see much better compliance with the high intensity, and also the dyspnea and the quality of life was much improved with the high intensity compared with the low intensity. And this is the confirmation that we need to have. So we need to confirm that not only CO2 goes down during the daytime, but you need to confirm that this episodic elevation of transcutaneous CO2 are under control. So it's important that you target your non-invasive ventilation levels according also with your nocturnal CO2 level. And this is what a Kernline study has shown us, that if you decrease at least 20%, you will get this reward in terms of long-term outcomes. But one thing that we must understand, and this is something that the group from Professor Stefano Nava in Italy has shown us, is that we know that high-intensity non-invasive ventilation just improves arterial blood gases, but there can be some decreases in cardiac output. So we must be careful with the heart. So especially when we have patients with hypercapnic COPD and comorbid cardiac failure. So we must understand that there can be a risk of some deterioration of your cardiac function. So the ATS guidelines suggest that we should not, it's not necessary to perform an in-lab overnight PSG to titrate NIV, especially if you don't have sleep apnea, comorbid sleep apnea. I think that we should only recommend this titration in lab, especially if the patient is struggling with the compliance, if there is some underlying suspicion, especially if you don't know if the patient has an overlap syndrome. So this is a very practical and important advice that in general, so full PSG in-lab titration protocol is not warranted for this patient population. So what about the new systems, so the new hybrid modes? Is there any evidence to support the usage of these volume assured pressure support modes versus the typical bilevel, simple bilevel mode? So according to the IRS guideline, currently there is no evidence that suggests any superiority of volume assured pressure support. And we know that some of the issues that appear quite often, like leakage, some like upper air obstruction, can interfere with the accuracy to deliver the tidal volume. So there can be some troubleshooting when you're using these volume assured pressure support, especially if you're not very experienced in analyzing your your evaluation of pressure and flow and your polygraphies, etc. So I think that it's important that this should be for more experienced centers. It's better that you start with the simple bi-level and then maybe in some cases you can think about this pressure with volume assured pressure support, but with some more detailed monitoring. So to conclude, I think I have said to you that there is evidence, substantial evidence now that can support the use of NIV for stable COPD. I think the favorable phenotypes are the ones with higher hypercapnia, so more than 52 millimeters of mercury, and the better is the stable hypercapnic patients. Patients that are non-exacerbated with relative preserved 6-meter walking distance. This is the Kuhn-Lines phenotypes, but also the Murphy's, the HOT-HMV phenotype, which are the hypercapnic COPD patients that are on the post-exacerbation recovery phase, so after 4 weeks. It's highly recommended that you use high intensity NIV, and it's important that you control compliance. So it's mandatory that your patient with COPD is using more than 5 hours. Otherwise, the results can be really below the expectation. And I think that there are more and more evidence, and we can discuss that in the Q&A phase, that the outpatient setup is quite cost effective and has the similar outcomes. So thank you again for your attention, and I will be very happy to reply to your questions.
Thank you very much, Professor Vink. We indeed do have a number of questions which were put in the chat here. Let's start with the first question, which is a question which came in from Ali, asking, for OHS patients that need NIV, which interface do you prefer and which is the preferred ventilation mode?
Okay, very good question. So as in all the cases, I typically start with a nasal mask. I think we understood with the more recent studies that an oral nasal mask can have some impact on the residual upper airway function. So it can increase, even on simple OSA, can also increase the residual event. So you probably will need higher pressures when you're using an oral nasal mask. So the first reply is, okay, nasal mask, but unfortunately, a lot of these patients have nasal obstruction. And so it's unavoidable that you will have to use an oral nasal mask. And I think more and more we're seeing minimal contact oral nasal masks that are much less claustrophobic, and our patients are much more keen to use an oral nasal mask than at the beginning of the era of sleep disorder breathing, where oral nasal masks were very bulky with a lot of harnesses and much more difficult to tolerate. So if the patient has not severe nasal obstruction, I will definitely choose a nasal mask. There is very severe nasal obstruction, and you can measure that by simple inspiratory flow maneuver. You can measure if there is a severe nasal obstruction that would make the nasal mask, the nasal interface, more difficult. Concerning the mode, of course, bi-level mode, and I would recommend also some backup rate, some minimum backup rate of 15 at least, and the titration, of course, is recommended to do in lab, because you need to increase the EPAP and the EPAP according with the events and according with the residual hypoventilation. Of course, that as I mentioned, sometimes patients with obesity hypoventilation are diagnosed in the acute setting. So when they are hospitalized, and during that setting, you have to do some kind of empirical titration. So based on your local directions, so maybe a daytime titration under some kind of monitoring. So I would recommend some belts and at least some airflow and saturation and CO2, of course. But I think that bi-level would be, especially for the ones that have more severe hypoventilation than obstructive events, I think bi-level should be first. But as I said before, some patients with obesity hypoventilation that have severe sleep apnea, more than 30 of AHI, can respond to simple CPAP. And this is probably much more easy in some contexts, in some centers that you don't have this facility to do titrations, even the daytime or nighttime, and maybe you can start with automatic CPAP.
Thank you. There seems to be a burning topic, because we also received an almost similar question from 3 different participants, and it has to do with your part on the ALS patients, where you talk about the upper airway obstructions, and basically the question that come in is if there is a role for auto EPAP in that population of ALS patients with obstructive events.
Okay, this is a very, very good question. But my first reply will be, I think that auto EPAP is not sufficiently sensitive to respond to the upper airway events that ALS have, because they are much more complex than the typical obstructive events of sleep apnea patients. So as I mentioned to you, these obstructive events can be due to collapse of the lower pharynx, can be the upper airway, can be the tongue. So it's not easy that the auto EPAP can be sufficiently sensitive to respond to these events. You can try, but I would not recommend. I would just recommend you to evaluate upper airway in ALS visually by video laryngoscopy. I think this is becoming my practice right now, because I think that this is really a Pandora box. The upper airway of ALS is really different from patient to patient. How they respond to positive pressure, how they respond to inexuflation is really different. So you have to understand what's going on at the baseline and after you set up and you titrate the pressure, because this is different stories, different scenarios. So it can be even the mask. If you're using oral nasal mask, it can be the mask that is inducing the upper airway obstructions. It can be the pressure itself, and then it can be the bulbar dysfunction that is also so complex. So probably you will need to titrate the EPAP manually based on a trial and error, or ideally based on visualization of the upper airway, because it's the only way you can decide upon increasing. I can tell you very recently, we had a patient that without evaluating the upper airway, we just were increasing pressures of IPAP until 30 and EPAP until 15, and the upper airway was still closed. So we are not seeing what was the cause. Was it because of the floppy epiglottis, so this backward movement of the epiglottis? Was it because of the flaccid, the hypotonic tongue that was going backwards? So the only way you can do this is by scoping the patient while he's on an IV. So this is a task that is not so easy.
Thank you. Another question from Mark, who first of all congratulates you with an excellent presentation. You mentioned that there is no proven benefit of volume assured pressure support. Do you mean specifically for COPD patients or in general?
Yeah, very good question. I only spoke about COPD because that was the PICO question of the ERS task force. So about the usage of the hybrid modes versus the fixed modes in COPD. So for now, we don't have still the evidence. Maybe it will come out soon. For other disease categories, I think maybe obesity hypoventilation syndrome will be a different story, although the ATS guidelines didn't mention about it. So the titration of pressures for obesity hypoventilation is based on the common IPAP and EPAP increases according with the events that you're seeing during the PSG. But there are some interesting evidence showing that the hybrid mode, so the volume assured pressure, can be interesting because in obesity hypoventilation, we see that the posture of the patient has some impact on hypoventilation. So if the patient lie on a supine position, they have more events and they need more pressures. And so by using these hybrid modes, these volume assured modes, maybe you can make the pressure more tolerable. So I would say that for obesity hypoventilation patients that cannot tolerate high pressures, so the ones that you have decided upon based on the PSG, maybe you could try the volume assured, or for the ones that are not 100% controlled with the traditional fixed bilevel modes.
Thank you. A short question this time from Jennifer. You have not spoken about humidification. What is your experience, when to use it and when not?
Okay, very important question. So I think humidification was a must in pre-COVID times. Now, at least in my unit, and I think in my country, in a lot of other countries, I think that humidification has become a little bit risky. But I would say that humidification is very, very important to increase tolerance. There are not so many robust studies showing an increase in compliance, a significant increase in compliance when you had humidification, but I think you will avoid a lot of side effects. And at least in my practice, I tend to prescribe an humidifier as some routine procedure for the startups, because I think it will definitely increase the compliance. And as we need the first month, the first weeks of the patient to be the more compliant, because they will define the long-term compliance of the patient, I think the more head-ons we can have to make the patient more compliant, the better. So if you use humidification, so the upper airway resistance will go down, so the dryness of the mouth will also be much less, and so I think the patient will be more compliant. And so for that reason, I would think that humidification is kind of a standard of care right now, and also because fortunately the industry has included in the platforms very good humidifiers, very good systems to increase temperature, and without having, this rain out effect that sometimes makes the patient, remove the humidifier because of having some water condensed on the mask and on the tubing. So I think that we have increased a lot of the quality of humidification. And I think, of course, for COPD patients and for airways disease patients, I think humidification is even also more important for the sake of secretion clearance. So I think that if you have a patient with a lot of secretion, if you put some dry air on their airways, I think you will have some increase in the risk of plugging, which is not really of benefit for them. So I would say that for patients with airways disease, humidification is also important.
Okay, thank you very much. And a last question here in the chat. What EPAP setting is recommended for the high intensity NIV group of COPD patients?
Very, very good question. I think the default for me will be like 5 centimeters of water. But I think that we'll need more studies on that, because we have seen some evidence showing that if you counteract the intrinsic PEEP by giving a little bit higher external PEEP, so EPAP, maybe you can have a better synchrony. We can have a decrease in the ineffective efforts. So I think that in the future, we will need to titrate this more personalized. We have seen some studies showing that some patients, to counterbalance their intrinsic PEEP, some COPD, hypercapnic COPD patients, to counterbalance their intrinsic PEEP, you need to go up to like 10 or even 12 of EPAP. Of course, that the more EPAP levels you will put, the less pressure support you will have, or the more IPAP you will need to increase. So it's a matter of balancing the pros and cons. So I would say that I would put the minimum EPAP level, so like 5, and then see if there is some fiddling, some titration you can do based on the tracing of the ventilator. So after you download the ventilator, you can see that there are some ineffective efforts due to some intrinsic PEEP, then you probably can increase a little bit more the EPAP. But I think that in the future, there will be some devices that could measure that for us automatically, and maybe this titration will be much easier. Of course, that if you have a COPD patient that has concomitant obstructive sleep apnea, probably you will need a higher EPAP level. That is because you have to open the upper airway just to counterbalance the obstructive events that these patients have.
Thank you. I said it would be the last question, but new question came in during your answer here of the previous question. There is a question from Emma asking if you use mouthpiece ventilation, and if so, in what patients, and how do you monitor them?
Thank you so much, Eva. This is a very important question. I didn't have the time to expand a little bit on that. Probably that will be a next webinar, I don't know. But I think that mouthpiece ventilation is very, very useful for neuromuscular patients, especially for patients that need daytime ventilation. And we know that some neuromuscular patients like Duchenne, muscle dystrophy patients, when they are on a late phase, they will need not only bilevel ventilation during the nighttime, but because they have now a diurnal hypercapnia, they will need to have also daytime ventilation. And I think that the most comfortable way to do daytime ventilation in neuromuscular patient is by doing a simple mouthpiece. And by doing mouthpiece, I mean volume cycled ventilation. So it's important that you understand that when you have a neuromuscular patient, let's say a Duchenne or an ALS, that is using bilevel during the nighttime, then you have to use a machine, a ventilator that can give you also volume cycle ventilation, because it's much comfortable, it's much more effective to use a mouthpiece ventilation with a volume cycle ventilator. And it's also important that you know how to titrate, because it needs high volumes, because mouthpiece ventilation by definition is intermittent. You just sip intermittently, you don't need to keep your mouth all the time in the mouthpiece. So it's typically performed by wheelchair-bound patients that go and sip whenever they wish. And it's also a good complement for coughing improvement, because patient can air stack with different volumes of air given by the mouthpiece ventilation. So thank you again, Eva, for the question, because I think that if you want your neuromuscular patients to be ventilated non-invasively for a long time, you have to use mouthpiece ventilation, because otherwise the patient will ask for tracheostomy, because it's not easy to have a mask all the time to cover the nose and the mouth during the daytime. It's much more easy to use the mouthpiece when you're eating, when you're speaking, and this is very effective, and we have a lot of good references. One is led by our dearest Michelle Chatwin and published in Respiratory Medicine some recent time ago.
Okay, thank you. I think there's nice coverage. All the questions have been answered. So thank you very much, Professor Vink, for a very interesting and entertaining presentation and your guidance on how to optimize long-term mechanical ventilation. I would also like to thank all of you that attended our webinar today.